Thank you to Health Education England and also to the UK Pharmacogenetics Stratified Medicines Network for inviting me today to present on the health economics of pharmacogenetics. I'll start off with a quote from Oscar Wilde, which is that we know the price of everything, the value of nothing. And I guess that's the starting point when it comes to expensive health technologies, whether they be new medicines, health technologies, interventions, diagnostic tests, and so on and so forth. And so pharmacogenetics is no exception. We need to know how valuable pharmacogenetic testing is in relation to commissioning a service. There is a challenge in terms of how do we define value. How might we enumerate value in order to calculate whether something is cost effective or not? And there are several strands to determining value. And this is a slide which focuses on the value of a treatment or a drug for cancer. And it outlines it into different dimensions, which include the clinical outcomes, as we might naturally expect, which include survival benefits, disease-free survival, recurrence, etc. But then moving from that, there may be some more aspects of drug therapy which are harmful, toxicity and adverse drug reactions, which are clinically impactful on patients and important in determining the overall value of a treatment. And of course, in this particular instance, for treatment toxicity in relation to treatments for cancer, we may have a range of different adverse drug reactions that might impact on a patient's quality of life. If we look in this dimension, we have other aspects which are to do with the emotional functioning of a patient. How much do they worry about the treatments that they're about to receive? How inconvenient is it for them to be administered treatments, etc., etc. You can well appreciate that there are several potential aspects of value that we may wish to consider when determining whether an intervention is or isn't cost effective. And much of this depends on the perspective being adopted. So from a patient's perspective, ultimately, they would be more interested in relief of symptoms, the avoidance of adverse drug reactions, improved health-related quality of life, and improved survival if it is a treatment or an intervention that might have an impact on survival. Prescribers would have a similar perspective on value. They would want, obviously, improvement in health outcomes, and they would be a function of these particular attributes. If they then look at a broader perspective, that of the NHS, and it's normally the task of NICE to determine the value of health technologies, then the interest is very much in terms of the quality and length of life, the innovativeness nature of the health technology, with special emphasis on end of life and improvements in life expectancy in patients with terminal diseases. We're also very mindful, of course, of non-health benefits, and these typically, though not exclusively, involve better use of NHS resources. From an industry perspective, so which might be a pharmaceutical industry if it were to be a new medicine, or maybe from a tech company if it was to do with pharmacogenetic testing, then obviously the main concern would be in relation to return on investment. And arguably from a societal perspective, then all of the above would be of interest and relevance in determining the value of an intervention. But I'll focus on what NICE does, because it is NICE, which is the organisation with responsibility for determining the value and cost effectiveness of medicines and also of genetic technologies. NICE assesses value using the currency of the quality adjusted life year. And the quality adjusted life year is a measure of quality of life on a simplified scale of 0 to 1, 0 being effectively being in the death state, 1 being in full health, and over time. So these two hypothetical profiles might illustrate a disease which the patient is largely in remission, but periods of relapse of symptoms which impairs their quality of life. And eventually there's a deterioration and the patient ultimately dies. Now, with a healthcare intervention, whether it be a new diagnostic technology or a new medicine, there would be an anticipated improvement in the quality of life, and there may well be an extension in the duration of survival. And so the area in between these two curves represents the quality adjusted life year, the QALY. And the benefit of that is that it can be used across any condition and for any type of healthcare intervention, because fundamentally the two components of health that we're most interested in are quality of life and quantity of life. You may ask, how is quality of life measured? Well, the instrument which is preferred by NICE is the EUROQOL 5D, EQ5D, which is a rather simplistic way to determine a patient's quality of life, but it assesses 5 dimensions, being mobility, patient's ability to care for themselves, perform usual activities, whether they experience pain and discomfort, and anxiety and depression. And depending on their combination of responses to these questionnaires, we can determine their health state utility, which then can be used to determine the quality-adjusted life years. So if we know how beneficial an intervention is in terms of how many QALYs it produces, the next question is, well, how does that relate to the additional cost involved in achieving those additional gains in QALYs? And when we have an idea of the additional costs and the additional QALYs, we can then assess whether the intervention is valuable or not, and whether it represents good value for money for the NHS. And what do we really mean by value for money? It isn't cost saving. There's barely anything which is introduced into the healthcare system which actually saves money. Very few and far between do we come across those types of examples. It's normally the case that there's some additional investment to be made for additional benefits over and above existing services. But then the question is, well, how much should the NHS invest for those units of improvement in health? And it's all to do with the notion of opportunity cost. What we want is to invest in health or healthcare interventions, which produce more benefits than there are displaced. So if, for instance, we invest in one technology service, there is an implicit impact on the health service, and that's some additional investment. That something else will be displaced or diluted elsewhere in the health system. There's a finite amount of money, and so if you invest in one area or move resources in one direction, it means you no longer have that same resource to be used as originally intended. So investments in any new technology represent an opportunity cost. And the fundamental question, as I've already mentioned, is whether the investment choice results in greater health benefits than those units of health which are displaced. And NICE has set a threshold or a threshold range to decide precisely what it means by value for money. And the depiction here, the paper going back to 2004 in the BMJ, was how much NICE ought to be willing to pay for an additional quality-adjusted life year versus the probability of that intervention being accepted or rejected on the grounds of it not being cost-effective. So there's 2 points of inflection here. Point A, it's about £20,000 per QALY. Any healthcare intervention which costs up to about £20,000 per QALY would really be accepted. It wouldn't be rejected on the grounds of it not being cost-effective. On the other hand, the interventions that cost more than about £30,000 per QALY are likely not to be accepted because they're not deemed to be cost-effective. And these are decision rules operated by NICE in determining whether new medicines and other healthcare interventions are cost-effective. But there are some exceptions to the rule. Some QALYs are more equal than others. So normal, everyday health technologies and most new medicines and interventions fall into this category of £20,000 to £30,000 per QALY. However, NICE determined a few years ago that treatments, typically cancer drugs, which can extend survival by 3 or more months in patients with a life expectancy of less than 2 years, should be valued at £50,000 per QALY. So those QALYs are about twice as valuable as other QALYs gained in people's lifetimes. And you might argue either way whether that's fair or not, but this is the policy by which we operate. And then we can extend beyond that. Medicines for very rare conditions, so long as they are very effective and generate lots of QALYs, their QALYs are valued at £100,000 per QALY, which is, well, it can be up to 5 times the value of normal QALYs gained by most prevalent conditions. And for these extremely rare conditions, where treatments are life-changing, and there may be gene therapies, etc., where life expectancy increases by 30 or more years of good health, then those QALYs are worth more than 10 times other QALYs. So there are issues to consider here. And when we hear about the research and investment and the improvement in the science in relation to rare diseases, we also have to acknowledge that the pharmaceutical industry is responding to that by investing in more and more treatments for rare conditions, which does put financial pressure on the NHS because they will be appraised and recommended at this end of the spectrum. There was some empirical work that was done a few years ago from the University of York, which tried to estimate what is the actual true value of this threshold. NICE originally thought it would be in the range of £20,000 to £30,000. The empirical work actually suggests it's closer to £13,000. So in theory, anything that's approved above £13,000 per QALY results in a net loss in health to the NHS because those resources have been taken away from other more valuable use. That's all by way of background to health economics as a discipline. I'll now move on to the cost effectiveness of pharmacogenetic testing. And I'll start with a couple of case studies relating to single gene testing. But I'll first demonstrate how we would approach the question of assessing the cost effectiveness of a testing strategy. This schemata here represents standard of care with no pharmacogenetic testing, and so people would be treated without a test having been performed. I'll focus on testing in the context of patients experiencing an adverse drug reaction, which is probably the greatest focus of pharmacogenetics to date. There will be a probability that a patient would experience an adverse drug reaction, or more likely, they would not experience an adverse drug reaction. If they were in this fortunate category, then we could estimate through trial evidence, through systematic reviews, meta-analyses, etc., what the benefits are in terms of the overall QALYs gained over their lifetimes or over an appropriate time horizon, and how much cost had accumulated. It's not just the cost of the testing, but there's no testing here, but the cost of the treatment is the cost of people visiting their GP, the cost of additional interventions, diagnostics, etc. Now, if a patient were to experience an adverse drug reaction, the likelihood is that the dose might be reduced, or they may be taken off that treatment and prescribed an alternative treatment. And so what we would do then is estimate the costs and the QALYs associated with this group of patients who have experienced an adverse drug reaction. And overall, given the probability of an adverse drug reaction occurring, we know what the average or the weighted average costs and QALYs are in relation to standard of care. If we move to the paradigm of the testing, a pharmacogenetic testing strategy, if a patient were to test positive for a given allele, then immediately they would be given an alternative treatment, or perhaps a dose would be reduced depending on what treatment this related to. And the assumption is that there would be comparable efficacy in the alternative treatment, or with the reduced dosage. There would be the implicit assumption that there would be reduced adverse drug reactions, because that's the whole point of testing in the first instance. But there's probably going to be greater costs incurred, because if you're prescribing alternative treatment, then by definition that wouldn't have been the first choice. So it might be second choice because it perhaps is less efficacious, perhaps is more expensive. But in the same way as in the previous slide, what we would do is estimate the total costs, the total QALYs associated with those who test positive for a given allele test. Now, patients who test negative are at reduced risk of adverse drug reaction, and so they would be given the treatment that was intended. There is still a risk. No test is 100% correct in the sense that there are some false negatives, people who would experience adverse drug reaction despite not having that allele. So if they were to then experience an adverse drug reaction, again, the same pathway, there would be some change in prescription or some reduced dosing, and we could estimate the total costs and QALYs. If they don't experience an adverse drug reaction, which would be at a higher probability than in the previous slide where there was no testing at all, then again we could estimate the cost and qualities. And I think you can hopefully see where I'm getting at, that for this pathway we can estimate again the weighted average costs and qualities associated with pharmacogenetic testing. And we would compare that with the previous slide, which is without testing, and to see whether testing results in an increase in qualities and increase or perhaps decrease in costs overall. Now, critically, as I've alluded to already, the cost effectiveness depends on what this alternative is and the probability of being prescribed this alternative medicine. So, for instance, testing may be less likely to be cost effective if the alternative is more expensive. So if there are more and more patients being prescribed an alternative treatments just because they have an allele, or if that alternative is less effective overall. Similarly, for very rare adverse drug reactions, despite them being very serious, you need to screen vast amounts of patients in order to prevent one adverse drug reaction. So the numbers needed to screen, the NNS, becomes very high, and so the value of the test, on average, diminishes the rarer the adverse drug reaction is. So an example relates to carbamazepine, which is treatment for epilepsy, often used treatments for epilepsy, but it is associated with adverse drug reactions in about 5% of patients. And these range in severity from macropapillary exanthema, which is just mild rash, which tends to resolve spontaneously upon treatment discontinuation, through to carbamazepine hypersensitivity syndrome, which is more serious, has associated mortality, but then at the extreme end, and this is a slide also that Munir presented earlier, is the Stevens-Johnson syndrome and 10, which is far rarer, 1 in 10,000, but it is associated with very high mortality. And we did an analysis to assess whether pharmacogenetic testing was cost effective in order to prevent these adverse drug reactions. But I won't go into that analysis because I'm conscious I have presented once or twice before, and maybe some people in the audience have already seen it. But what I will refer to is an analysis that was published by others, which relates to the B1502 allele of carbamazepine, which is indicated or specified in the product summary of product characteristics as being a particular is a caution. And I'll read this out. Before deciding to initiate treatment, patients of Han Chinese and Thai origin should, whenever possible, be screened for B1502, as this allele strongly predicts the risk of severe carbamazepine-associated adverse drug reactions. So there was an economic evaluation of screening performed in Malaysia to assess whether routine testing would be cost-effective. What they found, interestingly, and I think this illustrates my point from the earlier slides, is that you need to screen 222 patients to avoid one case of SJS10. And you might think, well, that's worth it, and I think their analysis indicated that overall it was certainly cost-effective. But there's a price to pay, because those patients, I think the prevalence of B1502 was in the order of about 10% in the population that they had studied, meaning that there were large numbers of patients that were prescribed an alternative anti-epileptic drug. And that drug was less effective. It was phenytoin or lamotrigine, I think. It was less effective in their analysis compared with carbamazepine. So you would screen 222 patients to avoid one case of SJS10, but at the expense of having 3 additional patients who would have uncontrolled epilepsy. So there's always a trade-off. And there's a tendency to focus on pharmacogenetics being very effective in reducing the incidence of adverse drug reactions, but there may be unintended consequences in other ways. This slide summarizes some cost-effectiveness estimates based on single allele tests, and the carbamazepine one, which this is a study that we had performed, 3101, showed it was cost-effective to test in European populations. The B1502 in the context of epilepsy, and in a UK study at least, where the prevalence is much lower, is not cost effective. It exceeds the nice threshold of £30,000 per QALY by quite some margin. Munir earlier this morning talked about the case study of Bacavir for HIV with HIV B5701, and it's now routine practice to test for B5701 prior to commencing a Bacavir. And in actual fact, this is an example of testing being cost-saving. It's less costs and greater benefits overall by testing versus not testing. Another immune-mediated adverse drug reaction corresponds to the treatments for gout. Common treatment is allopurinol, and there is association with B5801. This is, I'm sorry, my typographical error here. That should be about £48,000 per QALY. It's not deemed to be cost-effective to test routinely in patients presenting with gout, wanting to initiate on allopurinol. And similarly, and to a greater extent, testing in the context of patients with clozapine, with the HLA genes, is in excess of £2 million per QALY. So it would not be cost-effective to test routinely. And I guess this is the limitation of single allele tests, in that each time a patient presents with a particular condition, eligible for a given treatment, a test is performed, test results come through, prescriber changes the treatment plan accordingly. It is unlikely to be cost-effective, with a few exceptions. However, if you move to a multi-gene panel whereby in one go you can analyse and have the results of 50 or more genes, then suddenly it all becomes worthwhile. And the reason being, and I'll return to this slide, this would be represented a single gene test, as I've already mentioned. Even if you had a simple panel with 2 genes on it, you get the incidental findings of this second gene, and you can act on that. The information could be stored in the patient's electronic health records and used at a future time point if that patient were to be prescribed or to develop a particular condition that would warrant prescribing of an effective drug. And so you get these additional results for free. And if you increase the size of the panel, then you get more results for free. And the more that you include, the more cost-effective it becomes. And ultimately, it's whole genome sequencing, ultimately. But there are some economic considerations that underpin the assessment of panels and how we are to assess their cost-effectiveness, and extending beyond panels to also consider the delivery of a pharmacogenetic service for the NHS. And the distinction needs to be made quite clearly between what are fixed costs, which are related to the infrastructure required to deliver a service, the impact on workforce, training, education that we've heard lots about this afternoon, the systems that need to be in place, the technology, the IT, the decision support systems, etc. It's a long list of things that need to be in place before we just assess the marginal cost of testing. The analyses I've presented so far relate to the marginal cost. So it's how much does it cost for that one additional patient, assuming the infrastructure and everything else is in place. Marginal costs are useful to determine the cost effectiveness of medicines, of tests, etc. But clearly the fixed cost is an important consideration. The value of incidental findings can apply in 2 contexts. One is, as I've already described, future prescriptions, but more and more patients are polymedicated. The likelihood is if somebody were to be tested, let's say because they were to initiate warfarin, they may also have gout, and they may also be taking allopurinol, let's say. And so you receive the information relating to that prescription at the same time, and adjustments could be made in order to direct the prescribing of a co-administered or a co-prescribed medicine. So we did an analysis of the cost-effectiveness of a multi-gene panel, but this is a very limited one. It was an HLA panel. with the genes listed below the table here. And we found overall, for a panel with a cost of £50 to £100, that there would be an overall cost saving to the NHS in the order of about £380 per patient. There would be very small improvements in QALYs, but nevertheless, they are health improvements. Remember, adverse drug reactions are very rare. So you may have one or two individuals who have very large gains in QALY, but everybody else would probably have zero gains in QALY. So on average, it's a small number. So the probability of this particular gene panel being cost-effective was 100%. So we guaranteed that this is a cost-saving approach given the assumptions in the analysis. Now, if I went back 2 or 3 slides to the diagrammatic representation of how to assess panels, it is rather complicated, but we did develop the methods around these, and that can have utility in other contexts for larger panels, panels with metabolizing enzyme genes, etc., etc. But for this particular example, as I've already illustrated, £50 panel is both cost-saving and is more effective than standard care. There are questions that need to be asked, though, in relation to, well, when might it be appropriate to order a panel? Who might be eligible? On what basis? What clinical indication? Etc., with ethnicity, and so on and so forth. And I think these need to be bottomed out first and foremost before a service is to be rolled out. Panel testing may not be cost-effective in individual cases, by which I mean if somebody, as I've already alluded to, were to present with gout and a panel was ordered on the basis of the prescriber needing information about allopurinol, then it may not be cost-effective to order the panel at that point in time. But it would be averaged out by others being ordered a panel to make it cost-effective overall. I want to just draw an attention to an earlier slide I had about the willingness of NICE and the NHS to pay more for QALYs gained in rare conditions versus prevalent conditions, and make the distinction between prevention of rare diseases, which is effectively what we're talking about here, about preventing adverse drug reactions, versus treatment of rare conditions, which typically would be the orphan medicinal products. Now, there are incentives in place for the development of orphan drugs, which include 10 years of market exclusivity, and 50% of all new medicines approved by the European Medicines Agency last year were orphan drugs. Similarly, the FDA, 50% were orphan drugs, and that's increasing over time. And you can well appreciate why some of these orphan drugs cost several tens, if not hundreds of thousands of pounds per patient per year, and there is greater latitude in the consideration of cost effectiveness, meaning that these get on the formulary without many questions being asked. And I'll compare our case study on the left-hand side here, which was genotyping for B5801 to prevent allopurinol-induced SJS10 in people with gout, versus an orphan drug, afamelanotide, for this rare skin condition where patients have, well, the press would say they have an allergy to sunlight. When they're exposed to sunlight, they have blistering in the skin, they have pain, discomfort. It can lead to liver disease. So I'll go through some of these to compare and contrast. So the incidence, about 7 in 10,000 patients being prescribed allopurinol. It's rarer to have this condition, less than 2 per 100,000 patients. The presentation is far more severe in terms of SJS10 than it is in this condition. Prognosis is worse, there's higher mortality rate. If we look at the clinical evidence underpinning these two comparisons, there are 13 genetic association studies with B5801 allopurinol. That included 239 cases of SJS10. The clinical development program for afamelanotide included randomized controlled trials that included 259 patients. So it's comparable in terms of the data and the evidence generated. But then if you look at the cost per patient, we estimate that the cost of genotyping is about £55, whereas the cost of this treatment is 56,000 euros per year for the remainder of patients' lives. So the mean QALY gain is very small because only 7 in 10,000 actually experience the adverse drug reaction, but you have to test everybody, obviously, to be able to categorize them by their genotype. So there's a very small incremental gain in QALYs compared with a very large gain in QALYs with this treatment. Looking at cost effectiveness, we estimated it was about £45,000 in the context of allopurinol. That would not judge to be cost effective. NICE would probably think, well, as a single allele test, this would not be cost effective. Whereas for the afamelanotide, the cost effectiveness is between £200,000 per QALY and £1 million per QALY. But because it's a treatment for a rare condition, as opposed to an intervention to avoid a rare condition, then it is generally deemed to be cost effective and it's been approved in several countries and is currently under consideration by NICE. So I'll finish off just with some policy implications. It's important to consider value for money, which is where my main area of focus today, but also affordability. If a service were cost effective, but it costs £100 million to introduce, then clearly there are questions to be raised there. But in theory, even if it seems not to be affordable, if it's cost effective, then other things ought to be displaced in the healthcare system in order to make it affordable. Cost effectiveness critically depends on the alternative course of action, so which procedures, which doses are changed, which new medicines are introduced as a consequence of test findings. And panels are far more likely to be cost effective than single allele tests. And there's a final remark about the value of modelling these. It'd be impossible to conduct randomized controlled trials of a panel in these contexts, and so we need to rely on modelling and a greater appreciation and understanding of this type of evidence. I'd just like to acknowledge many collaborators and funding by the NIHR. Thank you.